because of this reason, the quality nutritional care, whereby we as a dietitian, we need to have this content of care. We are using the best evidence, the scientific, the protocols, the guidelines to help this patient together with our assessment, our screening, our diagnosis, and also our intervention and monitoring. Okay. So this is the currently, for example, the evidence guideline that available. For aspirin, there's a latest guideline on cancer, and we also have this MNT for cancer by our MDA 2016 to 2017. This best evidence or clinically evidence-based guideline and our expert opinion, actually it helps to guide healthcare workers and our patient also to putting this theory to this guideline into the practices. Let's say if we study or we read regarding clinical guidelines on cancer, actually for theory it's just straightforward, but when we come into the clinical practices with the cancer patient, it's a very challenging. So screening is very important, but it is unnecessary if patient already referred to dietitian by other methods, maybe the direct referral from oncologist or hematologist, because they only done the screening. Okay, so this screening actually to detect any nutritional disturbances, because not all cancer have the similar characteristics of the disease. Okay, and screening is need to be timely. Okay, it has to be timely, 24 hours upon admission for recommendation. So this is the nutrition care process. So screening is above, on top of our NCP. So the simple, the reliable, the quick only, we need less than 3 minutes is a malnutritional screening tool. We have other screening tool available such as NRS or MAS, but MST is very simple and it validated for the usage of cancer patient, because it's only have these two question, your appetite and also your weight loss. So if you have recent weight loss and you have decrease in appetite, the patient already at risk of malnutrition. So the recommendation of nutritional management actually it depends on the area. If you have this moderate nutritional risk, maybe you need to add in ONS for patient on top of high protein and high calorie diet. But if let's say patient have high risk of malnutrition, maybe you need to consider intensive nutritional support. So assessment. So assessment actually is very important. Either the patient is female, male, the current weight, any biochemical or any abnormalities, patient have this refeeding syndrome, medication, patient on chemo, radiotherapy, or CCRT, combination of chemo and radiotherapy. Diet history is very important. Is patient has this prolonged fasting, is patient on any fluid restriction, and the anatomy of intestine. Sometimes patient on ileostomy, colostomy, is the gut functioning well. So this one you need to assess. Assessment is very, very important. Okay, so routine assessment actually to assess the nutritional intake and of course the nutritional impact symptom that very synonym among cancer patient. So this is the PGSGA. PGSGA is a nutritional assessment tool. It's validated to be used for cancer patient. So they have these 2 pages. These first pages need to be filled by patient. The recent weight loss, any weight changes, any symptom, vomiting, diarrhea, dry mouth, mouth sore, altered taste, food intake, and also the functional status of patient. Patient able to do light duty or patient bedbound, they need to score themselves. So the second pages need to be by us, the trained healthcare workers, to see if there any increase in metabolic demand. We want to see the muscle status, the fat status, so then we can sort of categorize patient accordingly. Either patient is very well nourished, either mild to moderate malnourished, or severely malnourished, or any sort of nutrition impact symptom in between. So if you are well trained with this PGSGA, we can sort of categorize patient, and this PGSGA help to identify the overall global assessment. Okay, so our aim actually to maintain or to reduce the PGSGA score. And if let's say patient score more than 4, patient require intervention by dietitian. Okay, physical performance status is also very important among cancer patient to see the level of physical performance. If 4 is bed bound. So based on Muscaritoli, the latest study, if patient with disease progression and ECOG status more than 3, actually patient likely to benefit from nutritional status because of patient condition. But this one is only for disease progression patient. Okay, weight need to monitor weekly, especially if patient on treatment, and we need to monitor the nutritional impact symptom, the nutrition status, especially if patient on combined therapy, the chemo radiotherapy treatment. And weight maintenance or prevention of weight loss may be more appropriate with cancer patient than restoring the pre-illnesses weight. So if let's say patient current weight is 60 kg, we are better to maintain that weight either than we maintain the previous weight. Let's say the pre-illnesses weight is 80 kg. So we restore the current weight. And the goal target actually is the weight loss is less than 5% in a month or 10% in between 3 to 6 months. The guideline by expert also, patient with weight loss less than 2.5% and BMI between 25 to 28, BMI between 25 to 28, they predicted better survival. Okay. And then for the biochemical data, usually to in the indicator of protein status, because it's very crucial if you want to see systemic inflammatory, usually albumin and CRP. Clinical parameter, temperature, GI symptom, nausea, vomiting, diarrhea, and any medication or treatment that have relationship with nutrition. So is there any single parameter? Actually, there is no single parameter for the clinical parameter. You need to see the location of the treatment. If there is a greater nutritional risk as in the digestive tract system, what the treatment that patient currently receive, and any signs of nutritional risk, weight loss, and nutrition impact symptom that interfere the access to the food intake. So the dietary intake, we need to assess the appetite, sebab kadang appetite patient turun naik, sebelum ni okay, and subsequently after the treatment, the appetite reduce. The fluid intake, you need to maintain the hydration status and any food allergies. But to detect this nutritional risk is not our task alone. It should be as a teamwork. The oncologist, the doctor, the physician, the nurses, the pharmacist. We need to evaluate if patient only able to take maybe clear liquid or blended diet, days of insufficient meal, and detect if any difficulty in feeding. Maybe patient required assisted feeding or menu adjustment. So nutrition impact symptom. So this one is very, very important when we intervene the patient. We need to see is there any reason of weight loss? How about the eating adaptation, the dietary pattern, the quality of the intake? And then we cannot, we also need to see the physical functioning, whether a patient able to tolerate orally by himself or need assisted feeding. And then patient emotionally status, maybe patient is fatigued, depressed, and then the environment, because the social eating and eating adaptation is very, very important for patient to increase the oral intake. So this is the common nutrition impact symptom. This is the most common. Muntah, tak lalu makan loya, kurang selera makan, mouth sore, diarrhea, increased risk of infection or neutropenia, weight loss or cancer cachexia. So this side effect is can affect the ability to eat and maintain current level of nutrition. So for chemotherapy, the most common side effect actually is nausea, vomiting, loss of appetite, altered taste, altered smell, okay? And then if patient on hormonal agent, usually patient have increased appetite, weight gain, or fluid retention. And this side effect of chemo usually will go away within hours after treatment. But sometimes it can persistent up to 6 months post treatment. But the impact of this function can occur as early as day one of chemo.